So the biggest things that I look at in an individual who I'm considering for systemic therapy, frontline, clear cell with intermediate and poor risk features, is can they tolerate ipilimumab and nivolumab? I would choose that combination first because of the fact that it has the highest complete response rate and cure fraction. The challenge really is that there's a subset of individuals that if they were to develop some of the side effects like colitis, nephritis, hepatitis, that they may not have the physiologic reserve to really be able to sustain those toxicities and be able to get through them. So that's the first question that I ask. For those individuals who the answer is yes, they could, I will give ipilimumab and nivolumab. For individuals where they wouldn't, I would give axitinib and pembrolizumab. And for those individuals where there is some absolute contraindications to giving IO therapy, I would give cabozantinib.
The conversation we have when we first meet a patient with intermediate or poor risk kidney cancer has become relatively straightforward in our practice. The data for axitinib and pembrolizumab are so robust that outside of a clinical trial, and we do have trials in the space that we offer, it's really what we recommend. And that's for response rate and overall survival to be maximized. Generally with intermediate and poor risk, we know if we don't initiate treatment that the cancer will grow relatively rapidly. We know that from the prognostic curves. And so there it's a pretty straightforward conversation where that's typically what we recommend. There may be some patients who don't want treatment, some patients with autoimmune conditions that put them at a very high risk for adverse events with immunotherapy. Obviously, every situation has its nuances and has to be carefully considered. But in general, for intermediate and poor risk, I think until there are better data than axitinib and pembrolizumab, that will be our recommendation.
When we look at the 3 trials that underpin intermediate and poor risk patients in the frontline setting, it's really going to be the CABOSUN trial, it's going to be Keynote 426, and Checkmate 214. So Checkmate 214, up to 60% of individuals needed to take steroids at some point, and over 30% of these individuals had to take greater than 40 milligrams of prednisone equivalent per day. So there's clearly a lot of iotoxicity there. The Keynote 426 study, these numbers were considerably lower. They were in the low teens. And overall, that regimen was quite well tolerated. In the CABOSUN trial, really, cabozantinib didn't look like it was very different from sunitinib from a tolerability perspective, and it was really kind of what we expect with these with these types of TKIs. So the distinguishing feature really here is the rate of iotoxicity in the ipilimumab-nivolumab regimen versus the axitinib and pembrolizumab combination.